Okay. Hello, everybody. Welcome to our COVID-19 vaccine Q&A. I'm so excited to see everyone here and to talk to our two experts. Erin Ross is the lead COVID-19 reporter for OPB. She's a science writer and a former scientist. And Sam is a medical researcher at Emory, and he's studying vaccines. And if I got any of those details wrong, when I ask you your first question, please correct me. So we have so many questions to get through tonight. So I'm just gonna start, and I'm gonna start with the question that I think is on literally everybody's minds. We got several people asking when they specifically will be able to get the vaccine from various categories. We got a question from a woman who's 75, she's an RN. We got a question from someone who's immunocompromised, but not necessarily in the older category. We got a question about when will dentists be able to get it. So Erin, for these sort of specific groups who aren't just young, healthy, working from home people like me, when will we know, and when will we get our vaccines?
It's going to be a while before you can honestly have an answer to that question, unfortunately. So I can give you a bit more news than I could have yesterday. As of today, Oregon's Vaccine Advisory Committee has decided on who will be included in Phase 1B. So Phase 1A of the rollout for us was nursing homes, and then staff who work in those nursing homes, long-term care facilities, and then healthcare workers. And Oregon defined that group a lot more broadly than other states did, because we know that a lot of people who work in hospitals aren't medical workers. They are janitors, cafeteria workers, orderlies, and a lot of them are people of color. And what Oregon has seen is that that's how a lot of COVID is getting into communities, is through these lower level healthcare workers or non-medical healthcare workers. So that's kind of who Oregon's working through right now. That's a lot of people.
Sorry. So if you could keep yourselves on mute, that would be great.
Zoom.
If somebody could mute themselves, that would be great.
I think you got it. Zoom is tricky. It's totally tricky.
It is.
So we do know who else is going to be in the next group. We can say that, and we can say that teachers and people over the age of 65 are going to start being vaccinated on January 23rd. Now, we haven't heard any news about how we're going to get the vaccines out to those groups. Teachers should be easy. You vaccinated school. People over the age of 65, that's 660,000 Oregonians. That's a massive group. So that's who's next in line. Of course, we still haven't finished vaccinating all of our healthcare workers, right? So we've, especially healthcare workers who aren't affiliated with hospitals, just people who work in their own private practices or who do home care. We've had a really hard time getting the vaccine to those people in particular. So it's really hard to set a real timeline for when anyone will. I can tell you that the RN who's over 75 should have been vaccinated already, and hopefully will be really, really soon if Oregon can get the right vaccine, the right amount of vaccines to the right places. For everyone else, we don't really have even any prioritization for Phase 1B right now. And honestly, with 700,000 people between school workers and seniors, if we're vaccinating 12,000 people a day, which is Kate Brown's goal for the end of this week, that's going to take us about 60 days just to work through that group. If we can speed it up, it's faster, but just everything is so up in the air. The federal government keeps changing the rules for who you can and can't vaccinate. It's kind of a mess. So I can't tell you, but soonish maybe.
Yeah, well, that brings up a good point, and something that you and I have been talking about earlier is the idea of bottlenecks and where are the problem points in actually getting the vaccines into people's arms. So can you talk a little bit about that?
Yeah, one big bottleneck has been on the distribution side, and that issue has been that Oregon has struggled to get the vaccine to where it's needed the most. And so a lot of that distribution has come down to what they call the final mile. So Oregon can keep a lot of these vaccines need to be kept in special refrigeration right now in cold storage, not so much in the future, thank goodness, but right now that's a major barrier. And so Oregon has kind of figured out how to say get them to these distribution centers, but then to get them into people's arms, get them from there out, they haven't figured out yet. And so like in a lot of cases, they're waiting to vaccinate people until they know that they have enough people to use up all of the supply when they open it. Just a lot of kind of issues in that sense. But what we're really seeing is that there are a lot of hospital networks and a lot of counties that have vaccinated just about everybody, and a lot of hospital networks and counties where you still have ER doctors that haven't been vaccinated, even though they were supposed to be prioritized first. So some places are like itching. They are like so ready to start giving teachers shots and seniors shots. And some places are like, you know, we're still getting emails from healthcare workers who haven't gotten their vaccinations. So it's the bottlenecks are kind of all over the place, but majorly just in people to give shots and then in getting the shots to where they should be.
Yeah, great. And Sam, I'm going to pivot over to you with some science questions. So one question I see a lot and that we got a few related to was, so when you get the vaccine, you know, I understand that it sort of decreases the likelihood that you'll get the illness or that you'll get the extreme version of the illness, but does it actually, can you get infected still, and can you still spread the virus even when you have the vaccine?
Yeah, so this is sort of the $1 billion question. So you definitely can get infected, right? 5% of people weren't immune in that trial. They got, you know, not that 5% got infected, but compared to placebo, it seemed that a bunch of people were not immune even after the 2 full doses. And that was about the same in both the Moderna and the Pfizer vaccines. If you can get symptomatically infected, that means you have enough virus in you that your body is reacting to it. And I would definitely assume that you're contagious at that point. Mm-hmm. One of the things that the reassuring side of it is in the total number of like 33,000 people who got one of the 2 different vaccines, they only had 1 case of severe COVID. So that it seems that even if you do get infected, it's going to go much better for you than if you don't have the vaccine. So definitely you should get the vaccine. But so that's one side of it. The other part of it that I think is going to start to get talked about more, but hasn't gotten talked about enough, is the possibility that, well, okay, so if the vaccine doesn't work perfectly in everyone, so for some people, they still got sick, but maybe they would have gotten severely ill if they hadn't gotten the vaccine, and instead they just got symptomatic. Well, maybe there's other people who would have gotten symptoms, but now if they got the vaccine, they're actually asymptomatic, but still infected. And there's some data where if you take monkeys and you give them these vaccines, and then you wait a month or 2 afterwards, and you try to infect the monkeys with COVID, they do not get sick. But if you then swab their nose the same way many of us have probably been swabbed to check a PCR for the virus, you'll see the virus in the nose. And so if the virus is replicating in the nose, that suggests that you could asymptomatically transmit it. And so until we know more, I think we should assume, even once we're vaccinated, that we have the potential to spread the virus to people who are unvaccinated, even though it's likely that only a small number of us might do that.
Mm-hmm, mm-hmm. Yeah, that's good to know. And so sort of related, well, obviously related. Anyway, this mRNA technology that we are hearing about all the time. I think some of the vaccine hesitancy comes from the fact that this technology feels very new, and it feels like the vaccine was rushed and rushed with that negative connotation. So can you talk about sort of the fact that, you know, even though it went fast, that's not bad necessarily, right?
No,
so can you talk about that?
It's not bad. And honestly, the mRNA technology lends itself best towards a rapid development of a vaccine. Should I pull up my PowerPoint here, do you think, to kind of go through
Yeah,
it?
if you want to show some visuals about, you know, how the technology works and why it's new to us in the sense that it's the first time it's being used in a vaccine, but it's been researched for a long time. And I think that's an important thing that people that gets missed in the reporting on this.
Sure, issue. Yeah. Here, I'll pull this up just to go through what it is, just so people have the concept in their mind. I'll try not to take too much time on that.
Sure.
Hang on one second here. Oops. Sorry, small technical issue. There we go. So just very quickly, so like mRNA vaccines for COVID, and why they're not that different from the vaccines we've had, even though they are a new kind of thing. And anytime I say I have a PowerPoint, I always say I have no disclosure. So no one's paying me to do this. All the vaccines for COVID, whether they're mRNA or something else, they all make your body react to spike. Spike is this protein I've highlighted in green on the outside of coronavirus, and it's on different coronaviruses as well. And it's a huge protein, and it's the main one on the surface. So it's like, if your body can react to that, your body can go after the virus before the virus can go after you. Anything inside the virus there's a lot of bad stuff that lets the virus replicate inside your cells, but you can't get at that. The only thing you can get at is spike, which is on the surface. The mRNA vaccines, what they do is there's an interesting way that they get your body to react to spike. They consist of a piece of mRNA, which is genetic material, and your body has mRNA as well, lots of it in your own body. And the mRNA is surrounded by this little oily coating. When the oily coating hits your cell, the mRNA gets inside the cell, and then it starts doing its thing. And what is that? What the mRNA does, once it's in your cell, is it teaches your cell how to make that big spike protein. So you've gotten rid of you don't have anything dangerous from the virus whatsoever. All you have is this one protein that now your cells are putting that protein out on their surface. Your body recognizes this protein as a foreign protein, and it makes antibodies and it reacts to it, and that's what protects you. And so the end result is not that different from any other vaccine that you get. Most vaccines that you get are traditional protein vaccines. So I went over the mRNA vaccines. This is on the right. Protein vaccines. So in the mRNA vaccine, like I said, they give you genetic material and your body makes the protein. In the protein vaccine, they just give you the protein directly. Interestingly, if you give people protein as a vaccine by itself, it is worthless, almost completely worthless. Your body will ignore it unless you give an adjuvant, which is an irritating substance. That's why your arm hurts after you get the flu shot. It's not the protein component of the flu shot. It is the adjuvant that is irritating your body and activating your immune system. And then your immune system gets all jacked up and goes after the protein that happens to also be there. And that's how you make your antibodies. mRNA vaccines don't need an adjuvant because they're relying on your body to make the protein, and that in itself is a more natural way to actually present this thing. So interestingly, we worry about side effects from vaccines, but actually a lot of the side effects are probably from the adjuvants, because the adjuvants are inherently irritating and cause pain and inflammation. And the mRNA vaccines do not have adjuvants. So the only thing that happens that you can really react to or get an effect from is either the protein that your cells make, and then there's the oily coating that's around the mRNA. And I think that's probably triggering the allergic reactions that happen with mRNA vaccines, which, are unpleasant, but very short-lived and not long-term.
Yeah. So when I first learned about, when I first did a deep dive into mRNA and going back to my old days, taking genetics classes in college and trying to remember how that worked. One question that I had was, okay, so we're basically giving our cells instructions on how to make this protein. What stops that process from going haywire, in a sense where all of a sudden our cells are making that protein and then our antibodies start attacking our cells and all of a sudden it becomes an autoimmune disorder? What's
Sure. I mean, okay, so your cells make foreign protein all the time. We get infected by viruses all the time. all the time, and you don't get autoimmune diseases from that usually. And so in addition, this mRNA that you're giving, mRNA is a short-lived molecule. It degrades quickly. Personally, at the beginning of the epidemic, I was writing to my family, I was like, these vaccines are never going to work. But they work great. But I thought mRNA, it doesn't last very long. You're not going to get much protein. I can't imagine how they're going to work. But at the end of the day, that's sort of a benefit in that, your body makes protein for a short amount of time with the mRNA, and then the mRNA degrades, and the protein gets picked up and degraded, and there's a stoppage in production, and that helps keep things from going haywire.
Right.
Compared, like the way to make things go haywire is you need to keep having lots of antigen, and that'll cause a lot of inflammation.
Right.
That's more like an actual infection, like getting COVID might do that,
Can I ask you a question, Sam?
Oh, sure.
So I used to work on Zika, which is like one of like the few diseases, right? That just like, or not Zika, sorry, on dengue, which is one of the few diseases that's just like it's the second time you get it, your immune system goes haywire, right?
Yeah.
And that's been like a big challenge in developing a good vaccine for it.
Mm-hmm.
But not necessarily relevant to this, but I guess what I'm asking is, if I were to like get sick with a virus, my body would make immune cells that are receptive to that virus. I would make antibodies that recognize all of the antigens in that virus. But
yeah,
if I get an mRNA vaccine, like my body will stop creating these proteins at the point in which the mRNA just vanishes from
right. Yeah.
from the body, right? Like, because the mRNA that my body makes, it can keep on making copies of, but it's not copying this viruses, right?
Well, so I mean, your body.
How do our cells stop? Is it because the mRNA that we sent in, like we don't have the code for that in our DNA, so we stop replicating it?
Right. It's just, it doesn't copy itself. It's you're giving the body like a single template, like a single instruction. Based on that instruction, it can make protein, but it can't copy that instruction over like a virus will copy its instructions over and exponentially create a lot of new RNA and new protein. Whereas this is just a set rate, set amount until the mRNA is gone and doesn't work anymore.
Yeah.
Thank you. Yeah, that's awesome.
So
thank you.
Basically, bottom line, the what is being injected into us to make us immune to COVID, those genetic instructions basically just get shredded at the end of their job, and that's how the vaccine works. Another question we got about the vaccine is, sorry, I have to scroll all the way up. I think part of the hesitancy is also, long-term ramifications. This was an emergency authorized vaccine. We know that it's been doing well in trials. We know the trials have, involved thousands of people since, spring or summer. But it's still, it feels fast. So, how do you alleviate those hesitancies about long-term effects from this vaccine?
Yeah, I think this was a great question. And this was something I was really worried about earlier on. And then when I saw the data, I was extremely reassured. So when people say long-term effect from a vaccine, they sort of have this thing in mind where it's almost like if you take a medication too long, you eat a lot of tuna, you get all the mercury or whatever, that's not what this is, because this is a short-lived effect. So any effect from the vaccine, it has to start pretty early in order for your own immune system to create a persistent effect. So as long as your body's immune system is reacting to the vaccine, that's the time that you'll start to see an effect that you may worry is a lasting long effect, like if your body makes antibodies against itself and causes an autoimmune disease. We know that 2-month timetable of follow-up, because they followed people for 2 months, we know that that's when the antibody response got very high against COVID. So if there was going to be a long-term surprise bad antibody or autoimmune effect, it should have happened in that time. And what we have seen in, the 33,000 people who were followed for 2 months and now 4 months probably since they got the vaccine, we haven't seen anything like that. The main thing that we've seen is that is very short-term effects with the allergic reactions that are about 10 times as common with these vaccines as they seem to be compared to like a normal vaccine, basically, which, okay, so that's a short-term effect. If it happens, it's unfortunate, but it lasts a day or two at the most, and then you're done. And then I've gone through all the FDA paperwork on these, and there really isn't anything else that jumps out in terms of being significant.
Great.
There is one thing I've seen that I think it's worth reassuring people about. And it's just talking to healthcare workers who have gotten their first doses and second doses. And it's that when you get the second dose, be prepared to feel a little bit sick, but you're feeling sick because that's your body recognizing those antibodies or recognizing that protein and making antibodies and responding, just like you feel kind of sick when you're fighting off other viruses. So if you get your second dose and you feel sick, don't panic. Like that means it's working to some extent. And if you keep feeling sick, like call your doctor just in case. Because if you say got COVID in kind of this like wobbly time of immune system stuff, it's always worth getting it checked out. But like, just knowing that if you are one of the unlucky people who gets the second vaccine and you get a fever, it could entirely just be because your body is seeing this thing that it knows is bad and it's going, hey, I'm going to fight it. So a good thing to remember.
Yeah, I think that's a good thing. I think you should be like, yes, I have a fever and now I'm immune to COVID. My body is ready.
I have an ER doctor friend who was like, I got a really bad fever after my second shot. And I was like, congratulations. And she totally understood. So
great. So Erin, I'm going to kick it back to you. So you mentioned this 12,000 doses per day goal. I did get an update from OHA a little while ago saying that we reached that today. Yes, for the first time. So what steps are being taken to kind of ensure that we stay on this 12,000 a day path? And also, where did that number come from?
So that number was pretty arbitrary. Our previous goal was 10,000 a day. And then Governor Kate Brown announced in a press conference that came as a surprise to just about everybody that we had to reach 12,000 vaccinations a day by the end of 2 weeks. That was announced on Monday. I'm going for my own personal purposes, and plus it's a holiday week by like work week, so I'm calling Friday the end of 2 weeks. And we're supposed to be averaging 12,000, so we've hit it once. Can we maintain it? It's another question. It's also worth noting that a lot of the changes that OHA made immediately following that, like they thought that maybe if they opened up phase 1A to everyone and not just emergency workers, that would speed our vaccination rate. During that first week, actually, our vaccination rates fell. So the only reason, as far as I can tell, that we are hitting the 12,000 vaccines a goal day right now, or that we hit it right now, is that the program that we're using to vaccinate people in nursing homes has actually been really, really successful. So we've reached 50% of that target demographic of both patients and providers, which is wild. We are not at 50% of healthcare providers as a whole right now, not even close. Wow. But then, I'm sorry, I got lost. Nursing, oh wait, 12,000 a day. Okay, yes, sorry. So the rest of that is probably from a couple different mass vaccination sites that we've set up, but a lot of those have some pretty specific just requirements to go. Like there's a site in Salem, and I've heard of doctors driving all the way down because it was for a long time the only site in the whole state that was vaccinating everyone who was a healthcare worker. And it was only vaccinating Marion County residents. So folks were driving 2 hours and getting turned around. Good news, this is a scoop that my coworker broke literally like 2 hours ago and will probably be announced tomorrow. But OHSU, Kaiser, Providence, Peace Health, all the major Portland area networks are going to be teaming up starting next week to run a mass vaccination site. They're going to be donating all of their staff in Portland at the convention center. So that is some hot news gossip for you all. And I think we're going to be seeing the most improvement in this current group from events like that, because we've just kind of reached this point where like everybody who works in a hospital has the shot, but it's really hard to get it to people who don't. And right now, mass vaccination events are the best way. So I would expect to see our numbers kind of like zigzag up and down. It's not like we hit 12K and we're going to be there, but
Right.
hopefully we'll move faster than that, because if we hit 12K for ever, if that was our average forever, it
Mhm.
would take us until halfway through 2022 to vaccinate all of Oregon.
Oh,
So,
God. So we're hoping to exceed that, is what you're saying.
yes, very much so.
So another question that we got many times over for those kind of rollout side of things was, when certain groups are eligible, how will they know? Because we've been hearing, do not call your PCP, right? But also, how else are you supposed to know? Like, who's gonna email or text you, right? So how will you know? Do you need to sign up for a newsletter? I mean,
It's a really, really, really good question. And I would highly recommend anyone who has that question to write to the Oregon Health Authority and ask that question, because that seems to not be a major priority in their rollout right now. And to be honest, it's because they're really, really overwhelmed. Like, they are underfunded, they don't have the resources for this, and they are just treading water and trying to keep their heads up. So a lot of this like forward looking planning that is really necessary to do this well, they just don't have the capacity to undertake. Hopefully that will change as we get an infusion of about 10 million in stimulus funds on the 18th, 19th. And then hopefully additional, Biden just announced a big COVID-19 recovery plan that will hopefully send more aid our way.
Yeah.
But
And so once they establish kind of that like notification infrastructure, we should
yeah,
start.
I mean, maybe we don't have one yet at all.
Yeah.
And the thing to know is that other states have tried, and so far no one's done it particularly well.
Yeah.
Florida and New York used a sign up system. So you'd go in and you'd like fill out a survey and it would be like, yeah, you can, and no, you can't. But then the sign up system kept crashing. New
Yeah.
York's got like booked out through the end of June already.
Yeah.
So I don't expect us to have a really good answer on that anytime soon, at least not until the transition has happened and just things are a bit more settled, and hopefully we have some staff. Because right now, I mean, Oregon doesn't even have like, the only like get a vaccine public information commercials that we're seeing are from Senators Wyden and then from Kennedy on his reelection campaign.
Yeah.
Like, OHA hasn't even put out a get a shot, wash your hands cable clip, and
Great.
like Idaho has. I mean, come
Wow.
on, we're
Yeah. No offense to Idaho.
no offense to them. My family's from Idaho, but their COVID-19 response has been abysmal, and they have commercials telling you to wash your hands. So we only just decided who's in phase 1B. We are like really, we have one of the smallest healthcare networks in the country. Our rollout has been one of the slowest, and to a certain extent, that is just not the fault of the people who are currently there. It is just
Right.
chronic underfunding. Their budget has been cut by so much every single year.
Yeah. So we actually just got a question in the chat that I think is very relevant to what we were discussing a minute ago about if you get a fever after the second vaccine, that means like, yay, it's working, side effects, yay. But this person is asking, okay, well, if you don't have side effects, does that mean it's not working?
It doesn't mean it's not working. No, bodies are weird. And I see that Sam's on mute, but I also see that you look eager, and I'm going to say bodies are weird and move it to Sam.
Yeah, I mean, it's not an analysis that's been done. It's more like I say, oh, hey, you got a fever, you're probably immune. That's to cheer people up because they know their body's reacting to something. But the same way that when you get the vaccine, you don't get pain immediately. You get pain later. That later pain, that's inflammation, and that's a sign that your body's reacting to. So, if you had no reaction at all to the vaccine, I would be a little worried. But as long as you've got some pain in the arm, I think you can assume something's happening there. And then, the only way to know that you have immunity is to get antibody tested later on if you're really concerned.
Right. So to kick it back to Erin, in Oregon, are we getting Pfizer and Moderna? And will we be allowed to choose which one we want, or no, or somehow find out which one our medical provider is giving? And is there a huge enough difference that we should be concerned between one or the other?
I'll have like see if Sam's nodding to back me up on this, but my understanding is that there's really very little difference between the vaccines in terms of total efficacy. Like they are both really staggeringly, like both, they're just really staggeringly effective for a vaccine. Like compare it to the flu vaccine and other ones that we roll out, and it's pretty impressive.
Right.
Like
The flu
that,
vaccine
that,
has like a 60%.
does that check out with you, Sam? That it's like we're that seeing like 97% sensitivity and just yeah.
So like, I'm very excited about the 95%. The flu vaccine is also probably not so bad if you look at only 2 months after the vaccine, So like we if it holds up at 95%, it's a great vaccine. If it decays a lot, then we need to be careful. But yeah, I mean, they're the best vaccines we have for COVID on this planet that have been licensed. So,
Yeah.
you should get whichever one is out there.
Right.
Maybe the Moderna data for older people, like the way older people responded to Moderna was very similar to how younger people responded. Whereas for Pfizer, older people still responded really well, but younger people responded even better. So maybe Moderna's a little bit better, but I wouldn't hold out. I would get whatever you can get because you don't know when they're going to run out or when things are going to be available. Right. I mean, but I don't know.
Yeah. So for Oregon specifically, Erin, at this point, will you be able to, walk into your doctor's office and say, I want this one or I want that one? Or will you be able to even ask, which one you're getting?
Not right now. You will certainly be able to ask which one you're getting. You will probably, at least for the next few weeks to months, not be able to request one or the other because the Pfizer vaccine has really, really specific storage capacities that limit where it can be sent to some extent, although in other states, they're not quite as limited as they are here because we really just don't have that cold storage network set up. And Oregon kind of dropped the ball on ordering a ton of dry ice. So we don't. So basically, like that is a great vaccine, but only places like hospitals can administer it. So we're not sending the Moderna vaccine to places that have cold storage. And we're not sending the Pfizer vaccine to places that have or that don't have cold storage, obviously, because it wouldn't work.
Right.
So it's kind of a distribution Jenga, but the good news is we do have a ton of other vaccines that are going to come online over the next few months. Yeah. And a lot of those do not have the same sorts of storage requirements. So once we start to look at like the OHA kind of defines phases as like, or not the OHA, like the CDC kind of defines vaccination phases as like phase 1A, you have very little vaccine. You really have to limit it. You really have to like limit who gets it. And then like in 1B and like in phase, like the next phase, you're kind of looking at, it's still pretty limited, but you have more. And then the idea is that by the time you're kind of hitting the general population near the end of that train, there's so much vaccine, nobody cares. That's the goal, at least. That's their dream. So right now, you probably won't have a choice, but if you have like a 20-year-old super healthy person who doesn't work in I'm not a frontline worker. By the time I get the vaccine, I'll probably have some choice because there will be a lot of vaccine out there, not as much demand, and there's going to be more different types of the vaccine that can be stored and administered in more different types of ways.
Great. So I want to shift the topic a little bit to kids in school. So Sam, we know that the vaccine wasn't tested in people younger than 18, right? Do we have any idea how well this vaccine would work in kids? Do we have a sense of when we can even test that, or like when that can even be rolled out for kids?
Yeah, so that's a tough one, simply because the testing isn't there. And why don't they want to test it? It's because the liability is higher in children. So Pfizer actually was tested down to 16. So luckily, anyone who's 16 or older should be able to get it. Moderna to 18. They just started the trials for kids, but then they only enrolled kids aged 12 to 17. So at this point, still, we're not going to have any clinical trial data on younger kids. In terms of what this is going to mean, so first of all, I think kids will react great to this vaccine. We give kids tons of vaccines and they do great with all of them, usually better than adults. So in terms of protection from COVID, I would expect that to be fantastic among kids. For that matter, they do well with COVID as well, in terms of outcomes if they're under the age of 17. In terms of side effects on kids, I wouldn't think there would be any special things, except, one thing at the back of my mind is that some children, after having had COVID, get this autoimmune condition that is temporary. It's called multi-system inflammatory syndrome of children. And it's usually treatable, but it can make them very sick. And it's unclear what part of COVID is triggering that. So in the very unlikely event that spike protein were to trigger that, then in theory, you could trigger that in kids. In practice, I don't think that'll happen, for the same reason that we don't get uncontrolled reactions in adults, because it's a fixed dose of mRNA. And so you're not going to get too much spike protein. Things aren't going to get out of control. So basically, there could be something, but I think it's very unlikely. And I think kids will do great with the vaccine whenever, we choose to do that, to vaccinate them.
Mm-hmm. And so if, kids aren't going to be getting vaccines for a while, obviously, we're still in trials and we're not even trying out on younger kids. So Erin, what does this mean for school? And, we've heard that Kate Brown wants kids back in school sometime in February. We've heard that teachers are getting moved up the priority list. So what does this all tell us about school being in person anytime soon?
Oh, Nelly. Okay. Well, let's break it down a little bit, I guess, because I would first maybe look at why are we vaccinating teachers so early? And we know that we want kids back in school. We know that school is very important. Like, in my opinion, school serves the same sort of role that like soup kitchens and homeless shelters do. It provides a fundamental service that keeps kids healthy, especially if they don't have good home lives. So just to be very clear, I think that I would love schools to be open safely. We are currently prioritizing teachers in a way that makes it seem as though this is more of a political decision than a scientific decision or a decision with children in mind, because we have known for 9 months how to get kids back in school. And that is to institute the type of a lockdown, temporary lockdown that gets cases to a traceable and testable level. And then you can open schools. It worked in Europe. It worked in New York. It worked in Australia. It worked everywhere. And we never, ever did it. So I'm a little bit dubious about her concerns about children in school. I'm like just putting my biases on the table there. But, we know that kids can transmit the virus. We know that kids are less likely to get really sick. We suspect that kids maybe have like a lower transmission rate, but like honestly, the research on that is changing like weekly. So we didn't close schools because we were worried about teachers getting sick. I mean, we were, but that's not why we closed schools. We closed schools because we were worried about increased transmission. Schools are traditionally a hotbed for viral spread. And COVID may prove differently, but honestly, we don't have great data because we closed all the schools. So we don't really know how well it spreads in kids as much as we might in other ways. So opening schools, the governor put a lot of that into the county's hands. She kind of undid all of our like school opening benchmarks and just kind of said like, counties, you do you. There are some Eastern Oregon counties that have had 15 COVID-19 cases this entire year. And they live in rurally isolated areas where they have no broadband. They have, they're running on dial-up. Some people don't even have phones. There's no cell phone access. And you can't get, my dad's from Maine, so I'll say it, like, you can't get there from here. Like, they are geographically isolated. It's okay to open schools in those places because that town of 15 is not going to infect that town of 15 60 miles away. Here in Portland, Portland Public Schools has been really cautious throughout the pandemic. I don't see them opening until cases are lower. I just don't see that happening. They have not indicated in any sort of way that they want to. And they were some of the first to close because they recognized also that substitute teachers aren't included underneath this school staff group, and their substitute teachers are primarily retired over the age of 75. Like, there's a lot of reasons to not necessarily open schools right now, not the least of which being that if you open schools and if you're a kid and you see your grandparents and they're not vaccinated yet, that's a potential exposure right there.
Mhm.
So yeah,
It's
schools
just
are just a
not gonna
mess.
happen.
They're a mess. It's a mess.
Yeah, yeah. Well, that could be its own Q&A. So I'm
I'm
gonna
writing the story right now.
yeah. I'm gonna shift topics again because we still have so many questions to get through. Sam, let's talk about immunity from the vaccine induced immunity, and how long do we think it'll last? I think I just saw a headline about maybe the Moderna vaccine. We know now that it can give you a year of immunity. And, what is that? So basically, like, how long will you be immune after the vaccine? And is there a point where it's just going to become like the flu shot, or like we'll need a booster in 5 years? Like, how do we know all that? And what kind of research is going into that?
Sure. It's hard to say, right? If you're immune for, I don't know how they can say they're immune for a year for something that didn't exist until, 10 months ago. But so like when they've looked at COVID immunity, there's two kinds of immunity. There's antibody immunity from B cells, and there's cell immunity from T cells. And what they see over time, over like a 6-month period, is the T cells kind of drop, but the B cell immunity stays steady over at least a 6-month period. And actually towards the end of the 6-month period is when you start to see reinfections of people who have had COVID. So in terms of how long the vaccine will last, we don't know. I would think there might be some decay in immunity over time, but you really can't say until there's been enough time, and there really hasn't been enough data on that. I'd love to see some of the data from the people who got the vaccine originally, 6 months ago, to see where their immune systems are at. I'm not familiar if that's out there or not,
So
or if it's out there.
We don't have enough information yet to know whether in 5 years we'll need a booster, or if this will become like the flu shot we get every year.
Yeah, well, okay, here I can give you some guesses. These are guesses. I just want to be very clear. The Pfizer and Moderna vaccines, which are among the better vaccines that are out there, they put your antibodies at the level equal to the best 25% of COVID survivors. Okay, so that's where it matches up. And we know that COVID survivors start to have immune drop around 6 months. So that, to me, that suggests that there's going to be a drop, and it's going to be hard to figure out how long it'll be. A comparison from way back is, you guys remember SARS. Mm-hmm. So for the people who had actual original SARS, which is a different virus from COVID, but it's probably our best comparator, about half of them lost all their immunity at 3 years. Mm-hmm. So if you want me to make a guess, I would say in the single digit number of years, a lot, some of the immunity will be gone without some kind of booster, but I don't know.
This sounds a lot like the immunity that we do see for influenza, and that we've seen for the coronaviruses, right? That where you have this 3 to 6 month period of fairly good protective immunity, and then after that you get sick, but you might be less sick than you were before. Is that kind of what your beans are on? That's where I'm placing my bets.
It's
I'm a researcher.
Sure. I mean, it's better. It's going to be better than the flu. The flu has a lot of its own problems. The best flu vaccines are 50% effective. Usually they're 30% effective.
And a billion different strains. And
that's the other thing is our bodies have seen a lot of different strains of flu virus over however long we've lived. So whenever you get a flu shot, you don't make fresh antibodies against that flu shot. You make old antibodies that get reinforced by your new flu shot that might not be optimal for the new strain, but they're kind of good enough. For coronaviruses, most of us, barring the few that have been infected by SARS, our bodies have not seen anything that's at all that close to spike, at all close to COVID. So a lot of these antibodies are new. And actually the antibodies that are getting boosted, the ones that from distantly related cold coronaviruses, they actually go to very vulnerable spots in that protein. So they're not useless, actually. compared to the flu ones. The flu ones are probably way more useless. So I think it's I'm more optimistic, much more than the flu shot.
Great.
That
So
is so
we
cool.
have about 15 minutes left in our official time, but both Sam and Erin, can stay longer until about 8:30. So we still have a lot of questions, and we have questions coming in as well. So if you want to stick around, please feel free. We'll be here for another 45 minutes. Just wanted to make that announcement. So you started talking about different strains. And one thing that, we've been seeing in the news a lot is about new strains of coronavirus, possibly more contagious. It started in the UK and now it's here. And will the vaccine we have now, well, let me back that up. How common and surprising is it that we have, new strains? Should we be terrified? Should we panic about new strains? And the vaccines we have now, will those protect us against this current new strain we're hearing about and possible ones that might develop in the future?
Sure, yeah. So we shouldn't be surprised about new strains. They're expected. Because remember, this isn't a human virus. Some other animal, this virus is optimized for another species. And as it gets into humans, it's going to mutate until it optimizes for us. So it's going to get better at what it does. So this is all to be expected. And it's been mutating the whole way. The vaccine is definitely going to work. And I will tell you, spike, which your vaccine goes after, is an enormous protein. It's 1,200 amino acids. The most mutations we've seen in spike in these mutants is about 10. So that means less than 1% of the protein is different. So you're showing your body a version of a protein that's 99% similar to what's actually out there. So sure, maybe 1% of your antibodies won't work as well. 99% will. That seems pretty good. That should be fine. And in terms of being careful, I think you should be careful because the mutations are increasing the ability of these things to spread. So if you have, say, we're doing a really good job social distancing when it was warm outside, and now it's winter and you really want to see your friends and you're tired of quarantining and you know that you're 2 months away from getting your vaccine, just wait. They're only going to get like the versions of the virus that can spread better are the ones that are going to spread better, and they're going to be out there. So just wait and get your vaccine.
Yeah.
Could you just say that the spike protein is 1,200 amino acids?
It's enormous. Yeah.
Yeah. So if I can put that into context for everyone else, just the protein that your body uses to carry oxygen is hemoglobin, and it's 150 amino acids. Wow. So, I mean, I had never heard that number before, and it's oh my God, yeah, that explains why the vaccines are still pretty effective. Yeah. Wow, that's huge.
Yeah. So talking about, hanging out with our friends. So one question we got, let's say that you and your 4 friends have both gotten the vaccine, both doses. You've still been social distancing because you know that maybe you can transmit it still. Can those 4 people hang out, no masks, in their own little dinner party? Can they do that safely?
Yeah, so it's the short answer is yes with a big asterisk, okay? Because everything is a gray area, right? Because if you had 20 friends that did that, 1 out of 20, the vaccine didn't work on them. Okay. So that they're taking a risk. I would feel fine with 4 friends who are college students who don't live with any old people who are all vaccinated. So what if they get sick? They're probably going to do fine. Even if they get a breakthrough infection, they're going to do fine. But if you're, let's say you're a college student and you live with your parents and you got vaccinated because you happen to work in a medical laboratory, but your older parents didn't, for example, then you're putting them at risk, right? Because in theory, you could transmit it to them. But if you come from a household where everyone is vaccinated or where you don't care if they get COVID, then by all means, I think you can gather together. So, my wife and I were in our 30s, and, once we both get the vaccine, we don't live with anybody else. We'll happily go hang out with friends who got the vaccine, knowing that our risk for getting COVID is very low at that point. Our risk for getting severe COVID is extremely low at that point. So yeah, yes, with an asterisk,
Yeah.
But that's the whole point of getting vaccinated, so we can do stuff like that again.
Right.
And I would still wear a cloth mask in public, at least, so that you can set a good example and help protect others if you were to, say, asymptomatically pick it up. But
Right.
You'll have more freedom in your private life.
Right.
Can I comment on that you can hang out as long as they're all not at high risk or they don't care about COVID.
Exactly. So it sounds like even if, you and some of your friends and, maybe your parents have gotten the vaccine in sort of public spaces, we should still be taking kind of the mask precautions and, wearing PPE and all that. When will we know when we can stop worrying about wearing a mask to the grocery store? Like, is it about the number of people vaccinated? Is it about the proportion of the infection rate of your state or your city? Like, when do we start seeing, the lights at the end of the tunnel?
Sure.
When
Yeah,
can
so
we feel comfortable going to the grocery store without a mask, basically?
yeah, there's two endpoints to this. The first endpoint is that, let's say the vaccines work really well, transmission is down, it's so low that anytime someone gets COVID, you can find everyone who they interacted with and quarantine all of them and get the situation under control. At that point, you can take all your masks off because you can track cases. Another possibility is that we never get to that point, but that we know that the vaccine is really effective and is so effective that that ICUs aren't full, and that people who are vaccinated, we know they're so unlikely to get severe disease. And at that point, then you could also open it up and let people do their thing. And in terms of when that's going to happen, it's a little hard to say. I think do you want me to keep talking about this, or are we too short on time? So the summer brought a big drop in cases. COVID spreads indoors at least 18 times more effectively than it does outdoors. So, and probably even better, because the outdoor data where it did spread, it was there was still indoor bathrooms and things like that, where it probably was doing the spreading. So, the summer is going to bring a big drop in cases. And if you can vaccinate everyone by the end of the summer, you could knock COVID so far down that maybe, if you're lucky, you can get to the point that you're describing in, fall, winter of 2021. I think 2022 is more likely, but based on sort of the economy, they're probably going to open things up before we want them to. And so, you're asking me sort of a theoretical, what would we do in an ideal world? You would wait till you could control the situation, and it's probably not going to happen anyway.
Right. So Erin, can you kind of give the same answer, but from very hyper local, Oregon perspective?
Honestly, it's the exact same answer. Mm-hmm. It is the exact same answer we do know that this is, speculation. I don't have research to back this up, but I have a lot of case studies that Oregon, if you want me to get hyperlocal, has really dodged a bullet in the pandemic. The governor likes to say very often that we did a great job fighting it, and that's why our cases have consistently been so low. But when you look at our policies compared to other states with similar demographics, they're actually about the same. I think that Oregonians have been really good at staying home and staying safe. I also think that we like to do things that are really low risk for our primary hobbies. We just opened up 200 trails on the gorge, and every single one of them was packed. And so I could see us reaching a point, we might have a better chance killing COVID at the end of the summer if we vaccinated everyone by that point, which I'm very dubious about. But our caseloads in the summer have been really minimal. I mean, literally, like, we're finding, like 100 people a day, and that's if there's an outbreak at a workplace that makes it easy to locate.
Mhm.
So, like, we are in a better place than a lot of states are. I would not put any money on it staying that way, because I really think a lot of it's been luck and just pure good fortune. But I mean, if you wanted to, I could see us being a little bit farther ahead of other states in terms of safety, but I also think that the only reason that we are is that we're taking it seriously. So I would probably say, like, wear your masks forever. I don't know. I'm a big fan of, I would be very happy if what the US took away from this is what Asia took away from SARS, which is that masks are a really great tool if you live in populated centers, and they're really good at preventing disease transmission. And I would love to go another year without getting a cold. It's been really nice to go this year without getting one.
Yes, yes, it has been. And then just to remind everyone, the event was scheduled to end at 8:30, at 8, but our speakers are going to stay with us until 8:30 so that we can get through some more questions. So feel free to stick around, or feel free to, leave if you need to. So our next question, going back to Sam, about vaccines and their efficacy in various groups. We got a couple questions. One about vaccines in pregnant women, and vaccines in adults who have, immunocompromised, who are immunocompromised or are on immunosuppressant drugs. Can you talk a little bit about that? And while you do that, I'm just going to run and get my computer charger.
Just realized I was muted. So the pregnant piece is very interesting. They didn't trial pregnant women, so they didn't specifically approve it for pregnant women, but they also recognize that pregnant women are a good population to target. The vaccines that you don't use in pregnant women are live vaccines. So like the measles vaccine, for example, the chickenpox vaccine, these are vaccines that copy themselves over in your body. And if your host is immunocompromised, so pregnant women, they have a kind of a different immune system to a degree, and obviously the baby doesn't have a normal immune system. So if the replicating vaccine gets in the wrong place, there's theoretical risk to the baby. The mRNA vaccines, like I said, it's a fixed dose. You get what you get. There's no risk, theoretically, in my mind, to the fetus. So if you look, WHO actually still recommends against vaccinating pregnant women. It's a very conservative recommendation. Also, a lot of the vaccines used outside the US are not the mRNA vaccines anyway. I think anyway, I won't get into that. That's too far. But the point is, our pregnant doctors at Emory, they get vaccinated. And I think every pregnant woman who has a chance to, if you look at the CDC guidelines, it's like talk to your doctor, risk benefit. I'm a doctor of infectious diseases, and I can say, I personally, on a personal level, I would advise any pregnant person to get this vaccine, because it gives you antibodies. And when you get antibodies, when you deliver your baby, they will have your antibodies. And guess what? When are kids going to get vaccinated? We have no idea. When are infants going to get vaccinated? Probably never. They're probably not going to get vaccinated until they're like a year of age. So if you want to protect your baby, you go get that vaccine. That's my personal advice. It's not an official recommendation at this time, but based on my level of expertise, I feel comfortable sharing that. For other immunosuppressed people, so again, there's no risk to you in getting the vaccine because it's not replicating. The main risk is that your body might not respond. But if you are immunosuppressed anyway, and it's not going to change, you might as well try to get the vaccine. There's no risk in it. You can always get an antibody test to see if you respond. I'm actually working with someone in California where we're going to do a clinical trial on people with multiple myeloma to see how they respond, expecting them to maybe not respond so well, but we just don't know. And I'll tell you that because the mRNA technology is new and people haven't responded, they've responded better than we would have expected. So when you use protein vaccines like your flu vaccine, right? Old people they don't respond as well. That's why you get a special vaccine for people over age 65. when you use the mRNA vaccine, in general, seniors respond very similarly to younger people, much closer than they do with protein vaccines. So I don't know what it's going to do to immunosuppressed, but I would get the vaccine if it's offered to you.
On the note of both just immunosuppressed people in Oregon and also on the note of pregnant women, I can tell you that Portland area hospitals are also vaccinating women who work there who are pregnant. So just like Emory, again, like another nail in that coffin. And also that people who are immunosuppressed are going to be included in phase 1B of the rollout. We don't know yet how that phase is going to be prioritized, but as of today, they are officially included in that group. So they will be getting it next ahead of like me. So.
Great.
Oh, and I'll add one more thing. On the CDC guidance for who shouldn't receive the vaccine, the only people who shouldn't are people who have had terrible allergic reactions to things that we know are in the vaccine. Everybody else is allowed.
Great.
And correct me if I'm wrong, but aren't a lot of those things that you could be allergic to in this vaccine also things that you might have had allergic reactions to in previous vaccines, like eggs?
I don't think there's eggs in these vaccines.
I was confused
they're
about
mRNA.
that. I heard that and was like, "There's no eggs in what you're making," so that's part of why I was asking.
Okay, don't even get me started on the egg thing. There's so tiny amounts of eggs in most vaccines that unless you are like smelling egg kills you, you're fine getting the level of egg in almost any vaccine except like yellow fever.
And that's a topic for an entirely different Q&A. One of the questions that came in was again about the transmissibility of COVID even if you get the vaccine. So, and it also relates back to schools. So Portland Public Schools, wants to have has announced that they're looking for a limited opening, at the end of this month. If the school staff gets vaccinated, and we know kids, can still spread it and are not getting a vaccine, could, the teacher or a staff member, still pick up the vaccine and bring it home to their family or whoever their household?
You mean bring home the disease?
Yeah, so if like the teacher and other staff members of the school are vaccinated, but kids aren't, and they can still spread it, could that vaccinated staff member still bring it home to their household if they get infected?
Sure, theoretically.
Yeah. So
yeah, especially like if their immunity starts to wane, but one would hope, that everyone at high risk in their household is already also vaccinated, so it would kind of pose less of a threat.
Yeah. All right, well, that was an easy one.
One would hope, but if we're opening schools on February 15th and we're not going to start vaccinating teachers and seniors until February 23rd, and we know that teachers are going to be an easy group to vaccinate, I would expect that if you are a teacher and you live with people who are at risk, that is something that I would probably advocate for communicating to your district, and something that your district should be considering when they determine whether or not to reopen schools, that it's not just the teachers who can get sick.
Right.
Potentially, but also other people. So keeping in mind, immunity wanes towards the end, but like that's an important part of vaccine prioritization that I haven't seen teachers considering as much as whether or not they will get sick from kids.
Well, and also like, it's not like everyone's taking their masks off and coughing in everybody's faces, like you can open a school and wear a mask and be fine. We all mask up in the hospital, and most of the transmissions from the hospital are when people are doing things outside the hospital unmasked. Doctors in the hospital who we haven't had vaccines for ages, we sit in fairly close quarters. We wear masks, we're fine. So, you can do that in a school.
And PPS's limited reopening guidelines, for what it's worth, are really, really cautious. You're talking like cohorting of students, like they don't interact with anybody outside of their class. You're phasing what classes are there on each day, depending on what type of limited opening PPS is doing. You might only be opening the school for the students who really, really need in-person education, which we've been seeing. Some of that has even been going on during our total school shutdowns. So, yeah, a lot of variables to consider.
Yeah. So another question that came up while we were talking about the different vaccines, Moderna versus Pfizer. We know Johnson and Johnson's vaccine had some good news this week. So somebody was asking in the chat, should I, wait for, a better, potentially better vaccine? Is it worth it to wait, or, should I just get whatever is offered to me?
You should get whatever is offered to you. Also, I don't think Johnson & Johnson is better than the mRNA. I think the only thing that's going to compete, maybe the Novavax one is on the horizon. That looks really good. But I wouldn't wait. Just get your vaccines now while you have a chance. Yeah, I don't think there's any. I can't imagine the advantage to waiting, especially for one that's not licensed. God knows how long it's going to take them to go from licensing to producing to delivering. By then, maybe everyone will have a booster dose.
Yeah. And so you said that you can't imagine that the Johnson Johnson is going to be better than an mRNA vaccine. Is the Johnson, what other types of vaccines are coming out? Like there's Johnson Johnson, AstraZeneca, and those are not mRNA vaccines. What type of vaccines are those?
Yeah, so the Johnson & Johnson, I just Googled it because I didn't know what their efficacy was. It sounds like they're saying 90%, which to me is still not as good as mRNA. And we know the mRNA was tested in thousands of people. I don't know how many people tested Johnson one. Let's see. So the Johnson & Johnson and AstraZeneca, they are modified adenoviral vectors, which basically means they reprogram a non-COVID virus to express spike protein. That's a theme here. So that you have a little virus that has spike on it, but the virus itself doesn't have enough machinery to make you sick. And then they infect you with it. And what we've seen, like I think AstraZeneca's one was 87% effective. So like these numbers aren't as good as the mRNA ones for starters. Additionally, even though they use these modified viruses to get into you, but humans get infected with related viruses. Like the viruses that give you conjunctivitis, for example, are adenoviruses. So some people actually have antibodies against the adenoviruses. So when they're given the vaccine, sure, they see spike, they might react to spike, but what they also see is a whole adenovirus. And they're like, I recognize that. I'm going to block the whole adenovirus. And those people don't get as good an immune response, at least with the Oxford AstraZeneca one. Johnson will probably have a similar problem. Novavax is a protein vaccine with a very potent adjuvant. And that one I think is going to be a very good vaccine, but I still think it's months away. And, whereas that the mRNA vaccines, they've promised 400 million doses by the end of July. I can't imagine Novavax is going to get anything rolling, before the end of March anyway. So and it's going to take a while to ramp things up. So I would get the mRNA ones. You can sign up for the Novavax clinical trial if you look them up online, and if you don't live in Portland, because I think it was like somewhere far away in Oregon.
We do have a trial ongoing here through HSU, but they closed recruitment. But if I can add one thing on that note, which I understand now is not necessarily Linda's original question, but something that I've had a lot of people ask, which is that, as the vaccine rollout has kind of gone, there have been situations where there has been extra vaccine and people have had the opportunity to use it. And I've had some friends ask me like, well, should I get it now? Like my therapist was like, I'm a healthcare worker, but I work remotely, and should I get the vaccine? And she almost didn't do it. And when you're looking at a time right now where we're having trouble getting the vaccines and the people to the same places, if you have a chance to get one, even if it does mean like skipping the line, you're probably not taking it from someone else. If it's available to you out of your turn, it's because it's going to get wasted. Take the vaccine. Every additional vaccine is still a success, even if, if we could have gotten it somewhere else, that would have been better, but that's just not where they are right now. So like if you end up in a situation where, you get an email from OHSU that says, hey, family of employees, come skip the line, go skip the line. Don't feel bad about it. Skip the line.
Great. So going back to the idea of clinical trials, how long will the clinical trials last to establish long-term safety and efficacy of the currently available vaccines?
So the clinical trials, at least for the mRNA ones, and this will probably be standard for all of them, but I only checked for both mRNA ones. It's 2 years that they follow people. You have to keep in mind though that these trials had a placebo group, initially, right? They had a group of people who didn't get the vaccine. At this point, it's not ethical to not vaccinate them. So you have no comparator group when you're looking at long-term effects anymore, past a few months. And like I said, I don't think you need to look more than 2 months, just because anything long-term should start in that 2-month period. But yeah, so you'll have 2-year follow-up on them. Mm-hmm. Also, I'll just add that for those of us, at least in the Emory system, who've gotten the vaccine, I get a text from the CDC every day asking if I have symptoms. So like they're on it. They're following up with large groups of people to see how they're reacting to the vaccine.
Mm-hmm, mm-hmm. And just to pivot back to Erin, if somebody is, so this is a very specific question. Somebody whose, older parents are living out of state, currently and will be for the next few months, and they get, somehow the notification, you can get a vaccine now, I'm sorry, let me start that over. Can they get the vaccine if they're living elsewhere, and can they, come back and get it? Or is it only for, permanent, you are living here right now residents?
Nobody's checking residency on vaccinations. The general idea right now is that people aren't even necessarily at some of the mass vaccination sites checking to be totally sure that you're a healthcare provider. I think that people are a lot less concerned about vaccinating someone out of order than they are about vaccinating. And so they don't want to do anything that'll slow it down, because it kind of takes a long time to give these vaccines, because you have to wait the 15 minutes for a potential allergic reaction. And there's just like a lot of staffing logistics issues. So most people, and this is not finalized yet, but the impression that I get from talking to county and community public health officials is that, and talking to OHA, is that they're going to be rolling this out kind of by location almost as much as group. So like they're going to be like targeting, frontline workers by going to where they work. They're going to be targeting people over the age of 65 by starting looking at like congregate living facilities and then expanding outwards from there. You'll get vaccinated through your hospital and in other different ways. So I don't think there's going to be anybody like checking to make sure you're an Oregon resident if you get a vaccine, although apparently in Marion County they have been. But also that actually just reminded me of one thing, which is that if you are going to get the vaccine and you know that you are in a group that is going to require it, that is currently allowed to get it, and you are told, no, we're not vaccinating that group yet, that has been happening. It has been happening incorrectly. It's been happening because OHA put out a bunch of infographics explaining who is included in phase 1A and who they're vaccinating in the current like 1.5A phase, or phase 1AB or whatever. And that list didn't include everyone who is actually eligible. So a lot of home caregivers, especially those who work with people with developmental disabilities, have been getting turned away. If you look on OHA's webpage, they are allowed to get the vaccine. So like, if you know you can get it and they say no, fight back. Like push back, have OHA's page on your phone. The messaging that they're sending to doctors is not the same messaging that they like, does not reflect the official policies. So that is something to be aware of. Go by that webpage and like bring that up. Sorry, that was a digression, but
no, that's a
bunch today.
Disturbing thing that's happening, and I'm glad you mentioned that.
Yeah.
So a couple questions we've gotten are about allergies and allergic reactions, that kind of thing. People with shellfish allergies, are they safe to get the vaccine? And people with like autoimmune disorders?
Yeah.
Great.
I mean, they'll make you sit there for a half hour instead of a 15 minutes afterwards. I have a bee allergy. They made me sit there that long. They may not be thrilled to vaccinate you necessarily, but the only strict contraindications are if you're allergic to something in the vaccine. And this is to the best of my knowledge. The allergy guidance has been changing, every couple weeks. So this is true right now. I don't know if it'll be true tomorrow.
Great. Okay, let's see here. Oh, one question.
And sorry, for autoimmune, definitely you shouldn't worry. You're not going to make like anti-mRNA antibodies if that's what you're worried about. They haven't seen that. I was worried about it at the beginning. It's even like your body is constantly assaulted by mRNA. Like we think of this as like a foreign thing, but every time you get infected with any cold virus, you're getting hammered with mRNA and you don't make antibodies against it. So you should not worry about that.
Great. And then a question about exposure. If you've gotten your both doses of the vaccine and you spend time with someone who then, texts you a few days later and is like, oh my God, I have COVID, and you know that you've had a COVID exposure, should you still be quarantining if you've gotten your 2 doses?
Well, yeah, I mean, that's, I don't know. I don't know what the guidance is going to be. In my mind, theoretically, you could transmit. So, maybe you wouldn't quarantine, but you'd be a lot more careful. But I think until you know more, the safest thing to do would be to quarantine. But if you're vaccinated, everybody else in your house is vaccinated, you don't need to quarantine from them, right? They're vaccinated.
Well, great. And then another question that came in when we were talking about clinical trials was sort of asking about the timing. Why do we do a 2-year follow-up if, any issues might only show up, after 2 months or a few months?
I'm not sure.
That's just like a clinical trial rule.
Maybe it's more practical. To do 2 years is like a set amount. But yeah, I don't know the answer to that. Maybe it's just to be reassuring and kind of help guide people. Like I said, in this case, I don't know what you're going to follow up when all your participants are going to have gotten the vaccine anyway. So I don't know what you're going to compare things to.
Right. And then for rollout purposes, is there a current place where to find out where the vaccines are available by group, like efforts to minimize waste?
I thought that was a great question and a genius idea, and boy, I sure wish there was. The way it works right now, it's honestly pretty hard to even like track where our vaccines are going. OHA they basically put out every week. They basically write in and they say, we want this much vaccine to this location, this much this location, so on and so forth. And there is also a minimum size to what that shipment can be. So that's about 1,000 doses, which is part of the reason why like small counties have gotten vaccinated so fast. Because if you only have 30 healthcare workers and you get 1,000 doses in a shipment, like you're set. What do you have to worry about? So yeah, that would be a really wonderful thing. But right now, I mean, in some cases, OHA hasn't even known about vaccine shipments arriving until a little while afterwards. And that's just because it takes so long for it to like go from like them to the county, from the county to like a person at like the bottom of OHA to somebody at the top. And like, it just takes so long. And, we don't have any sort of centralized healthcare system. And Oregon's is actually one of the most decentralized in the country. And we also have one of the smallest like healthcare systems in the country. The official line is that that's because we do great primary care, but we also don't have that many primary care doctors compared to the rest of the country either. Wow. So I would love to see a clearinghouse basically. And right now that's probably not going to happen anytime soon, but that would be a very smart thing to do.
Yeah. Let's see. Oh my gosh, I just had something in my, will we get to a point with rollout where, it'll be like a drive-through, come get your arm stuck situation? I mean, will we get to that point where you can just say, we're doing vaccinations for 8 hours, come on down?
That's kind of what's happening. That's kind of what's happening, just with specific groups in mind. I mean, Salem's is, we're here all day, come and get the National Guard to stick you in the arm. And then similar deal with the convention centers program. Yeah, but it's also important to remember that this strategy of like vaccines, come on down, is not going to work to reach a lot of the populations that have been the most impacted by COVID-19. Someone pointed out today during the Vaccine Advisory Committee committee meeting, and I was like, God, why didn't I think of this before? But like, can you imagine our migrant farm worker communities showing up to get a vaccine at a site run by the National Guard? No, they're not going to trust them. Why would they do that? So, really looking at like meeting people where they're at is really the best way to roll this out. Not necessarily big sites, although they're very useful for big groups like teachers and healthcare workers and over 65s to make sure that we're like actually getting the vaccine where it's needed the most. It's going to be looking at like these small scale events through different community centers, working with networks that people know and respect. So like going to like different churches and things like that, and like religious centers and centers that serve to refugees, just places that people know they're safe, and also places that we want to go anyway. And those are also places that we look for news. Like everyone comes here to the congregation to look for news. So those are going to be the places that are going to be pretty central, at least currently as it stands in Oregon's like long-term rollout plan.
We haven't, let's see, the influx of questions has kind of slowed down. So unless anybody has, a very pressing question that they want to make sure to get answered, I think we can start to wrap it up. Yep. So someone in the chat, I live in a 55 plus community. I wish they could use this as a vaccination site. Yeah. So actually that leads to the question, Erin, how is OHA choosing vaccination sites?
That is also going to be up in the air. We should be getting a bit more information on this week, hopefully. Linda, you'll be happy to know that there is a woman on the Vaccine Advisory Committee who was specifically fighting for you. She is like, I want to make sure that people who are younger than 65, who live in these congregate living centers or these more independent living senior facilities get the vaccine, because you're still in a big transmission locus. And so they are officially on the list in phase 1B. People who are under the age of 65 will also be getting vaccinated in those communities. The question of like how, again, is going to be kind of iffy, but part of the reason that she was advocating for vaccinating everyone in these communities is that it's way easier to just show up there and give everybody the shot than it is to say, hey, everybody who's over 65, come here, So I think it very well might be a vaccination site. Who knows? Well, hopefully more news coming out probably Tuesday. That's when, so OHA is taking the recommendations that the advisory committee gave them, and then they're going to run it by their lawyers, and then they're going to run it by like their kind of logistics team that's working with all of these other like healthcare networks and community centers. And from there, they'll come back to the advisory committee saying, hey, here's what we've come up with. Like, how do we sub-prioritize within this? So hopefully Tuesday, fingers crossed.
Yeah. And so a last question that's come in about, travelers who are vaccinated, are they safe to visit their vaccinated relatives after being on a plane? And I think the answer to that is sort of similar to what we've been talking about, which is if everyone in the household is vaccinated, then, and you're also vaccinated, it's probably safe. But if somebody in the household that you're visiting is not vaccinated and they're either they don't care or they're low risk, then yes, it's probably safe. But again, there's still the possibility that you can be infected and transmit the virus even when you are vaccinated.
Yeah, I saw that. They also wrote that the person was 97 flying. So, I would feel real iffy about that. Even knowing that older folks respond well. I mean, 97 getting on a plane, trusting the vaccine with very limited follow-up data. I don't know. Because what if they did get COVID? That could mess up whatever years they have remaining.
My advice would be like, regardless of COVID, maybe you fly to visit them and quarantine for 2 weeks in a hospital if you're or in a hotel if you're working remotely. Yeah. And like true quarantine, that doesn't mean going down to the ice machine. That's not a lockdown, but
yeah,
like don't put your 97-year-old relatives on a plane right now.
Yeah. Great. Well, unless Sam or Erin, you have any final comments or final messages you wanted to get across, I think we can wrap this up and call it a huge success.
Yeah, I guess. Go on ahead.
Oh, sorry. My final comment is that we're going to get a lot more data over the next 6 to 12 months, and it may contradict a lot of the things you heard here. And that's sort of the nature of this.
My final comment is basically the same. Did Sam freeze?
I think he froze. Yeah.
Oh,
you froze.
Sam. You sounded like you finished, but you froze.
Oh, my internet connection is unstable.
Yeah, so you were saying, we might hear things that contradict what people heard tonight, and that's just kind of the nature of the scientific process. And we learn more information, and sometimes things can change, and that's good and okay. And it's not, flip-flopping. It's not, oh, they were wrong. It's we're learning more and more.
And that's about my same thing, which is just like the final line, or like my bottom line is like, I wish I had more solid information with you or for you, but the fact of the matter is that like, even at like the highest levels, nobody has any solid information. When Kate Brown announced that she was going to be expanding it to people age 65 and older, that was because she had about half an hour before received an announcement with no prior warning from the federal government asking them to do so. So like everyone is scrambling. Everything is going to change. I joked with my coworkers that like twice a week, Kate Brown blows up every story that I've been working on with a new policy, or the federal government does, or someone does. So like everything I've told you might be wrong tomorrow. And I'm really sorry if that's the case. Just it's going to take a long time.
We were thinking about having a part 2 in a few weeks. So just in case things have changed a bunch. So stay tuned. If you'd like to get notified, subscribe to the CNS Cause newsletter. You can do that at nevershalom.org/COVID-19. And Esty, maybe you can throw in the chat a link where people can subscribe to the newsletter. Just sort of for logistics, so this session was recorded, so we will be uploading it to YouTube in a few days. Esty will, timestamp every single question, so you'll be able to go back to the questions. Keep in touch with the Congregation Neve Shalom COVID-19 Outreach and Services team through the newsletter. Esty just threw that in the chat. CNS Cause offers services, resources, COVID-19 services for those who've been affected by COVID-19 in the Portland metropolitan area, Multnomah, Washington County, and Clackamas County. You don't have to be Jewish to receive our services. Anyone can receive our services. And that newsletter will have information about how to get in touch with us. We'll have another Q&A, maybe about vaccines, maybe another topic in a few weeks. So and you can follow us on Facebook to find out that news as well, the Congregation Neve Shalom Facebook. And again, thank you everybody for coming. Thank you to our speakers. This was wonderful. I learned so much. And thank you for staying on longer. I think we actually got through all of our questions, so that was wonderful. And we still have 24 people on, which is great. I think we started with around 40, so we kept people around. And yeah, thanks so much. And everyone have a good rest of your night.
Thank you all very much.
Yeah, bye.
Thanks. Bye.